case-based lecture, and we're going to have 4 cases. 3 of them are ones that I was directly involved with, and one of them was a gift from Professor Obstruction, so we'll go through those. So the first one will be about a liver cyst, the second one, hepatic fibrosis, the third one is a case of pyrexia of unknown origin, and the fourth one is a case of biliary obstruction. And okay. So this is a 58-year-old woman, and she presents with right upper quadrant pain, with bloating, tiredness, no weight loss, but she does have reduced appetite. She has some comorbidities, well-controlled hypertension, and she's on irbesartan for that. She's a non-smoker. She does drink 2 to 3 drinks per night, fairly heavy drinker. No family history of note, but she does own a sheep farm. So on examination, she had a tender right upper quadrant, no signs of chronic liver disease, had a palpable smooth liver edge. She's a little on the heavy side, her BMI was 30. Blood tests, full blood count was normal, eosinophils normal. Her erythrocyte sedimentation rate was slightly elevated. Liver function tests were essentially normal, but she does have elevated ALP and GGT. This is a little bit elevated, maybe not out of keeping with someone who drinks as much as she does. Normal bilirubin. An ultrasound scan was organised to investigate the right upper quadrant pain, and she was found to have a diffuse fatty liver, a very common finding amongst our patients, 2 small mobile gallbladder stones, and a complex 15-centimetre cyst in segment 7. So I never remember the liver segments very well, so I've put a picture up there. Suggestive of hydatid, no communication between the bile duct and the cyst is evident. So a question for the audience, is this hydatid disease, or does she need more tests? If you were going to treat this, how would you treat it? And this is a CT scan, not an ultrasound scan, estimating the size of the cyst there. So before we try to answer the question, let's go through a little bit about hydatid. That's a disease caused by the tapeworm Echinococcus. It causes visceral organ cystic hydatidosis. There are 4 species of Echinococcus that cause infections in humans, but the most common are Echinococcus granulosus and Echinococcus multilocularis. And in Africa, we see Echinococcus granulosus, with multilocularis mostly being in Northern Europe. So this is the little worm that's got these characteristic little hooks by which it attaches to the intestine. Okay. So this is the geographic distribution of Echinococcus granulosus throughout the world. And while it's quite endemic to parts of South America and also to Northern Africa, Australia sees quite a few of this as well, and the rest of the world. So in the life cycle of this organism, and you'll see a few of these pictures as we go along, the human is not part of its real essential life cycle. It's kind of an accidental host, or it's not a part of its actual life cycle. So this is a classic prey and predator kind of organism. So the predator will deposit feces, and that in that feces it'll have some eggs. The prey will eat it. And then the cysts within the sheep form within its organs. And when it's eaten, like a piece of liver or kidney is eaten by the dog, then that will recommence the life cycle of the organism. And humans get into contact with this by accidental ingestion once it passes the intestine of the dog into the human. And there, the oncospheres are released in the gut and then can travel throughout the portal circulation to anywhere in the body. So these cysts, Okay, so the hydatid cyst is a true cyst. It's got 2 layers. The inner germinal layer is filled with fluid, and the germinal layer creates these hydatid fluids, and also the smaller secondary cysts that are called brood capsules. Great name. So the protoscolices, or the larvae, are produced within about a year within these brood capsules, and these are fertile, so they can spread this way. In addition, there's an external membrane that's acellular, but does stimulate the immune reaction to cause a fibrous layer. And in this way, clinical ways and they can be found in almost any site with the liver being affected in 2/3 of patients. It's really rare to see symptoms in granulosis before 10 centimeters of size. But the cyst rupture, and depending on where it is, it can cause biliary colic or obstructive jaundice. It can even cause pancreatitis. And then there can be a mass effects on the bile ducts or the portal or hepatic veins or even the IVC. You can get cysts, as we said, anywhere. The lung is a fairly common secondary site after the liver. And this is a shadow on the lung. You can see the beautiful round cyst being formed there. And in the lung, the cyst rupture can cause hemoptysis or pleural effusions and empyemas. And there's some great grisly pictures on the web of these beautiful cysts that are found in the pleural spaces. But the other problem with cyst rupture is that it can actually cause an immune triggering and hypersensitivity or even anaphylactic reaction systemically. So, and Haidadid has been with us for a very long time. Back in the 70s, they developed a classification system of it. The serology for Echinococcus, then its negative predictive value is very poor. So if it's negative, it does not mean you don't have the disease. But ultrasound scan has a very high degree of sensitivity. And the classification of the cysts, the formation of the classification system was to try to develop a way for being able to predict how we should treat them. So it has evolved to try to say whether the cyst is active reproductively, whether it's transitional on its way to being walled off and ignored and died and dead, or it's inactive and therefore the organism has no reproductive capability. And this will influence how you're going to treat the Haidadid cysts. So what are treatment options? If they're really small and they're localized, then these can be actually just treated with albendazole alone. And if it's not causing a mass effect, and perhaps it's been found accidentally, then you can get away with just treating with albendazole for a few weeks. But if the cyst is causing a mass effect and you want to treat it, then there are some invasive or non-invasive ways of treating it. So the least invasive way is probably radiologically to puncture the cyst directly, aspirate its contents, and into the same needle you can inject a protoscholicidal agent and then re-aspirate to remove the contents. And now you've ablated the cyst. This is less invasive than surgery. It has the advantage of being diagnostic and therapeutic, and in appropriate cases, the cure rate's over 95%. Because there's always a theoretical risk of cyst rupture, the recommendation is to use albendazole administered before and then for a month or two after the treatment, even though it's localized. It's not suitable where you've got a risk of cyst rupture. So if it's a superficial cyst that's close to the edge of the liver, then puncturing it could rupture it. If the cyst is already ruptured, then it's certainly not suitable for aspiration. If there's stuff in the cyst that can't be drained, so if there's solid material that can't be sucked out, then you'll end up leaving potentially material there, and that won't be suitable for drainage this way. Cysts with the biliary communication can't be treated this way, which goes back to our case, which you expect the radiologist to be able to tell you if there's active communication or not. And inactive calcified cysts can't be treated this way because the wall may not be able to be punctured very effectively with the needle. And also if it's soft, if it's hard, it won't collapse with the aspiration. So for complicated cysts, with cysts where there's a lot of daughter vesicles and extrahepatic cysts, then surgical treatment is the ideal way. And whether you use albendazole as the definitive therapy, it certainly has a role as adjunctive therapy. And it's the primary antiparasitic agent for Echinococcus granulosis, with praziquantel being a reasonable alternative. So back to our case. So we had to look at the options with this lady. We considered our options. We could drain and ablate it. We could surgically excise it. We could give her medical therapy. Now, this cyst on ultrasound was classified as type 3A. Now, 3A is supposed to have like floating membranes in there, and I guess on a different cut or plane, we may be able to see those. But that's a cyst with detached membranes. So how would we go about treating this? Well, in 2019, the BMC published this lovely little treatment algorithm, which I found to be quite useful going through this. So you have a liver hydatid. If we follow it down, she's a Garby type 3 because she's got complex cysts with membranes that are floating. Yes, she had abnormal liver function tests. However, in her case, I'm not sure that the abnormal liver function tests were really related to the hydatid disease. She was moderately obese. She drank a fair bit. Nevertheless, if we say that it is, then yes. Word about cyst location. Well, hers was in segment 7, so fairly deep in there. And is it larger than 14 centimeters? Yes, it was 15 centimeters. So she would be suitable for open surgery. And in fact, she was offered medical therapy as an adjunct, and albendazole was commenced. She underwent an intraoperative drainage and cystectomy, and she continued albendazole for another month or so afterwards. And she had no further treatment. She's remained well. Okay. So case here is just to remember hydatid, that there is a classification system that's based on the systemorphology, and it will influence treatment. Serology is not really reliable, and it may be worth repeating an ELISA if you really want to determine whether or not it's hydatid. Be careful, the cysts can get traumatically ruptured. To some degree in Australia, we see a fair bit of hydatid from amongst our farmers, but and I guess to some degree, we underestimate how important it is. Mortality is supposed to be fairly high after 10 years if it's left untreated. And I could only really find a couple of papers, but they estimate the overall mortality is around 1.29 per 100 patients overall. I don't know what's happening to this. Okay, so go to the second case. This is a 54-year-old man who was referred to our general practitioner to our liver clinic with a very helpful note. Thank you for reviewing Mr. W. He had some blood tests and he's asymptomatic. So armed with this knowledge, I received my patient. He's a Chinese immigrant to Australia. He's working as an acupuncturist, and most importantly, his daughter is a doctor. Possibly he has had some treatment for schistosomiasis as a child in hospital in China. He only remembers this because his dad had the same treatment with him, but his dad actually died years later of hepatocellular cancer. So examining him, his BMI was 28. There were no signs of chronic liver disease. Back in August, the general practitioner had done some blood tests, and they had shown that his fasting blood sugar level was 7.7. His bilirubin was normal, ALT was elevated, his alkaline phosphatase was okay, GGT was okay, globulins were okay, hemoglobin was fine, and his platelets were okay. At the time, the general practitioner had organised schistosoma serology based on the patient's history. That was negative. He had also gone ahead and done some blood tests. His HCV was negative. His Hep B surface antigen was positive, however. His DNA was undetectable. He had a low-level antinuclear antibody that was elevated, but his liver screen was otherwise negative. Now, at the time, back in August in the patient was commenced on metformin on the basis of having some insulin resistance, and he himself put himself on a weight loss program. By the time he saw me in April with fresh blood tests, his bloods had fully normalized, including his fasting blood sugar level. He'd lost several kilograms in weight, and he had an ultrasound scan with transient elastography, which is a very similar test to having a FibroScan done. And it gave us a reading of 7.8 kilopascals, showing some evidence of the equivalent of maybe F1, F2 fibrosis. But his surface antigen was positive. His surface antibody was negative, certainly hadn't cleared the virus. His E antigen was negative, and his Hep B DNA remained undetectable. The GP had organised a CT scan on the basis of the first blood tests, and this had shown that there was evidence of transient multifocal hepatic attenuation differences in deep segments of the liver. And they said, well, there's no lesions here, but the differential diagnosis is that the patient has fibrosis within the liver or liver cirrhosis. So In summary, in this case, we have a man in his 50s who has hepatic fibrosis of an unclear cause. He's got a background of probable, maybe schistosomiasis. There's a strong family history of hepatocellular cancer. He's had some insulin resistance in the background. His surface antigen is positive, his Hep B DNA is negative, and his ALT is normal. So the questions for me when he came to the clinic is, does this man need HCC surveillance? Should we be doing ultrasound and bloods on him, alpha-fetoprotein, every 6 months? Does he need treatment for his Hep B? And does he need any other treatment? So let's talk a little bit about schistosomiasis. This is a parasite that lives in certain types of freshwater snails. There are quite a few species of schistosomiasis, and each snail has its own kind of environment and its own schistosomiasis. So it's unusual to find different species of the disease together. The male schistosome has a groove in which the female lives, which is one of the characteristics of this species. And infections tend to occur in rural areas. So schistosoma mancini and hematobium are the two most common forms of schistosomiasis in Africa. And schistosoma mancini occurs in Sub-Saharan Africa, but also in South America and the Caribbean islands, whereas hematobium is also found in Africa, but also in the Middle East. The other forms of schistosomiasis I won't be talking about too much today. So here, in part of this cycle, life cycle of the schistosoma, humans are part of its natural life cycle. We start at 1. The eggs that are in the water enter the snail species, where they undergo the first part of their life cycle, and that through the snail, the cercaria are released into the water. They penetrate the skin, usually feet or legs, or in children through the skin, and there they deposit, going through the circulation and through the intestine, and deposit in the intestine or into the bladder wall. And so they're passed from the human out through the feces or the urine back into the water, and so therefore they complete the life cycle there. So most of the public health measures in trying to break the problem with schistosomiasis have been to attack this through sanitation, so we can stop the release of eggs directly into the water, getting rid of the definitive, the intermediate host in terms of the snail. But they've also been looking at whether or not we can treat the patients potentially with immunization. So these are research that's ongoing. So clinical manifestations, acute schistosomiasis doesn't really give a lot of problems. You can get a localized dermatitis at the site of larval entry on the feet or legs. There is something called acute schistosomiasis syndrome. So every medical student in Australia learns about Katayama fever. I don't think I've ever seen a case of it personally, but you guys probably have where you live. It occurs 3 to 8 weeks after infection. It coincides with the beginning of egg production and rapidly increases as there is more antigenic burden. And the symptoms are really allergic type symptoms. So you can get onset of fever, urticaria, angioedema. They are very short, usually mild and self-limiting over a period of days to a few weeks. The problem really with schistosomiasis is in chronic infection, and we see it later. And this can happen in endemic areas with ongoing exposure as patients get re-exposed even after treatment. But it can occur in travelers as well. The severity of the disease appears to be directly related to the antigenic load. So the number of eggs that are trapped in the tissue, their anatomic distribution, and the duration and intensity of infection. The symptoms are often insidious in onset, and they can depend on the organs that are infected. So hepatosplenic schistosomiasis, there are 2 phases depending on the age and of the burden and the duration of the infection. And in children and adults, you get a non-fibrotic granulomatous inflammation, which occur around the trapped eggs in the periportal spaces. And then, and usually there's no sign of liver dysfunction, but this generally progresses to getting periportal fibrosis. At the early stages, where it's just all inflammatory, the changes are reversible. So if the patient is given treatment with praziquantel early on, then you can actually stop and break the cycle and stop chronic inflammation leading to fibrosis. Hepatosplenic schistosomiasis in adults with chronic infection eventually leads to collagen deposition in the periportal spaces, and this is mediated by hepatic stellate cells. And you can see the sort of thickened appearance there. This causes the classic pre-sinusoidal portal hypertension with occlusion of the portal veins and massive splenomegaly. But interestingly, throughout all this, hepatocellular function is preserved. It can make diagnosis quite difficult. It is, of course, a gastrointestinal infection. So yes, you can potentially see changes of this in endoscopy. Patients can present with abdominal symptoms, intermittent abdominal pain, poor appetite, diarrhea. It can cause chronic ulceration, bleeding, and iron deficiency anemia. It can even lead to a sort of a pseudopolyposis type syndrome. And chronic inflammation can lead to strictures or obstruction, and it is a rare cause of acute appendicitis. Schistosomiasis can occur throughout all the organs, so certainly there can be pulmonary and genitourinary symptoms. Renal disease is described, and so is neuronal disease, depending on where the schistosomes lay. Well, I'm not going to go into those. The classic manifestation is that of massive portal hypertension, and this is compounded by a few different things. So massive portal hypertension and the hepatosplenomegaly can also lead to malnutrition. Chronic diarrhea can lead to malnutrition. So you end up having this problem with massive ascites that's compounded by both low albumin and the portal hypertension, which we see in this poor child. It can cause some of the most dramatic varices I've ever laid eyes on. It's a serious disease in Africa, causing over 200,000 deaths per annum. And these deaths are mainly due to complications of portal hypertension or cardiopulmonary disease. So the diagnosis can be tricky. The classic is that of looking for schistosome eggs in the stool or urine, and that's the gold standard. Serology, well, it's supposed to be more useful where the burden of infection is low, and it's useful in that the antibodies will turn up before eggs are detectable, but it can't distinguish between past infection and active disease right now. Antigen detection tests are becoming more popular, and they are a very high sensitivity even when the parasite burden is low. And of course, molecular testing and PCR are gold standard. So what about point of care tests? Well, this is where the gold is in the future, I think. The Cato CATS test, that's the stool test for eggs, is very easy and cheap to perform, but it requires a lot of paraphernalia, and it requires a certain degree of expertise in doing this. So basically, it's looking directly with stain by microscopy for poo, for eggs in the poo. So in low endemicity countries, Cato CATS test has quite a low sensitivity, and in highly endemic areas, it's much more sensitive. It has, of course, the advantage of being around for a long time. People know how to do it, but it does require expertise, and it's cheap. The DNA PCR or LAMP, I guess this is the real new gold standard. It's even in prevalences studies as low as 8% prevalence, it has a sensitivity of 96 to 100%. These are the new sort of tests. There's a CCA, a cathode antigen test for urine. There's one for serum as well. And even in low endemicity countries, it does well, 57 to 64%. But in moderate or high endemicity countries, you're getting up to 92% sensitivity. So it's easy to perform, particularly the urinary test. So I think we're going to be seeing more and more of this. At least in the last 5 years in the literature, there have been increasing numbers of papers published on this, so it's good. So what about treatment? With chronic infection, praziquantel is the gold standard for treatment. In endemic areas, even a single dose is curative in over 85%. And if it isn't curative, at least reduces the schistosoma burden by more than 90%, and a repeat dose after a couple of weeks may improve curative rates. Is it cost effective? Well, on average, when I looked up the price of praziquantel, it's 80 cents per tablet throughout most of the African countries. It can be as low as 40 cents a tablet in some places that are quoted. And, to me, it seems that even a single dose or 2 doses during childhood is something that people have trialed. There was a trial in South Africa looking at just treating children en masse, and they tried to do a cost-benefit analysis on this and found that the cost was not so much the cost of the drug that was prohibitive, but actually getting the personnel out to administer the medication. So perhaps a decentralized approach to ensuring that there's timely treatment may be one option. Resistance to praziquantel is an extremely rare event still, thank goodness. And what you want to really do is treat before complications arise, because once the fibrosis happens, it is to a great degree irreversible even after treatment. So in summary about our patient, going back to our little man, he's got hepatic fibrosis, and that evidence for that was that we saw fibrosis mildly on the elastography. That wasn't greatly helpful, but definitely there on the CT. The degree of fibrosis may be unclear, but he definitely has some fibrosis at least. He's got a family history of HCC. He's got a potential for insulin resistance that may come back and therefore give him fatty liver on top of this. He's got surface antigen positive, but he's got no DNA yet detectable, and his ALT is normal. So do we need to survey him? Does he need treatment? And does he need anything else for his Hep B treatment? So before we went on, I thought I'd just quickly look at Hep B and its treatment indications. The EASL guidelines say you need necroinflammation and fibrosis, but also an increased viral load. Well, he doesn't have that. Cirrhosis and a detectable viral load, no, he doesn't have that. ALT that's elevated and a viral load that's up, both of those he doesn't have. E antigen positive and an age greater than 30, no, he doesn't fit that criteria. Family history of HCC or cirrhosis, well, he does fit this. What about the WHO criteria? Well, they're looking at diagnosis. So question comes down to, do we consider what this gentleman has, which is periportal fibrosis, not cirrhosis, sufficient to treat the Hep B or not? And I think that the data is still a little bit unclear on this. Important to note that schistosomiasis serology is unreliable for past infections. So I don't have proof that he had schistosomiasis. Does it matter at the moment? Probably not. So I decided that he definitely needed HCC surveillance. I'm not 100% convinced that he needs Hep B treatment at this stage, but considering his daughter's a doctor and considering that treatment isn't very expensive and considering he might get HCC later on down the track, my indication for treating him, my barrier is very low to commence treatment for him. So probably with more discussion with him, we will commence treatment. Does he need treatment for schistosomiasis? Certainly not at the moment. So the case 3 is a case of pyrexia of unknown origin. This is a 44-year-old Ugandan man who'd returned from a trip home 3 weeks ago. He visited, or 3 weeks before I saw him at least, he visited home in his home village, and he visited Kampala, and he'd gone at around December. He presents with weight loss, fevers, headaches, and loss of appetite and jaundice. He traveled with his family, and no one else in the family was sick. He didn't take any malaria prophylaxis at all. His temperature in the emergency department was 38.5. He was tender in the right upper quadrant. He's a fairly thin man with hepatomegaly, and he was jaundiced when we saw him. So his full blood count showed a little bit of elevated neutrophils. He had hepatitis, AST and ALT were both elevated. His GGT was elevated, and his bilirubin is elevated. And this is not the same units that you guys usually use. So to convert this, I think this would be a bilirubin of around 10 or so it's elevated. So in the following hours from arriving in the emergency department, he became quite delirious. He had a single convulsion with a fever of 39 degrees, and he'd been admitted to ICU for support. Not knowing what the diagnosis was, he was commenced on broad-spectrum antibiotics immediately. It took about 24 hours to get his film back, but once the blood film was reported, he was GIMSA stain positive for malaria. His antibiotics were ceased, and he was commenced on, at the time, parenteral chloroquine. This case was from around 15 years ago or so. So we're going to talk a little bit about malaria. Plasmodium falciparum causes almost all of the cases of malaria in Africa. This is spread by the Anopheles mosquito, and it's responsible for 409 deaths, 409,000 deaths. Malaria worldwide happened in Africa. I am not going to go through this extremely complex life cycle, which is basically split into 2 or 3 rounds of replication of different stages of the malaria life cycle. In brief, the mosquito is required for part of this life cycle. So elimination of the mosquito would effectively eliminate malaria. But there are 2 stages of the life cycle, the blood stage and the liver stage. And both of these targets have been the ground for much research into treatment and prevention of new malarial infections. The clinical manifestations: fever, malaise, headaches after within 2 weeks of getting infected. CNS involvement of falciparum malaria is a very poor prognosis. What about the liver? Well, yes, acute hepatic manifestations can occur, and they're usually not a good sign. So you can get jaundice from either unconjugated bilirubin being high due to hemolysis, or due to actual liver hepatitis. And the mechanism behind liver hepatitis in malaria is unclear. A mild transaminitis is actually really commonly reported, but high transaminitis is quite unusual, and it is considered a sign of severity. Often the hepatitis can happen a little bit later in the course of the infection, and therefore it can be confusing because it may be related to the drugs treating malaria in the first place. It is a known cause for acute hepatic failure, and the resultant unwellness of the patient manifests by hypoglycemia and worsening of the metabolic acidosis, and of course they can't metabolize their drugs. The pathology is unclear, but if you do a biopsy, you see signs of hepatocyte necrosis, granulomatous lesions, Kupffer cell hyperplasia, cholestasis can be seen, and monocyte infiltration of malaria nodules in the liver stages of the infection. So the geographic distribution, this is the worldwide distribution of falciparum malaria. And clearly Africa bears, Sub-Saharan Africa bears the overall burden of this disease dramatically. There's been the graphs from 10, 15 years ago show the disease to be significantly more widespread previously. So we are winning in terms of beating this in some areas due to just vigilant control. So what about co-infection? Hep B is endemic in these areas, and so is malaria. What happens when you get co-infection with these 2 conditions? In Ghana, there haven't been a lot of studies on this, but there's one study from Ghana showing that the prevalent in pregnant women, and I guess you pick pregnant women because they come in for their blood tests as part of their workup for pregnancy and peri-pregnancy care. So the prevalence in pregnant women is shown to be around 13.4% of malaria alone, 7.5% of HPV alone, but only 1.7% of the population had both malaria and Hep B. The parasitemia in this study was associated with lower transaminases and a lower viral load of Hep B. And the higher HPV viral load was associated with higher transaminases. So the question that they raised was whether there was an immune interaction happening amongst these patients such that having Hep B was actually somewhat protective against malaria. And a meta-analysis that was published, in 2020 looked at all of the studies that had been published on Hep B and malaria together, and they said that there was a 6% pooled dual prevalence of the disease. A couple of other studies, they quoted 10% in Gambia and 7% in Nigeria. And there was no difference in the ages, in the gender, ALT values between mono and dual infections. So I think the data is still unclear as to whether it's a negative correlation between these. But I mean, most patients who get this have Hep B from birth. So therefore they'll be Hep B pre-infected before they get the malaria. And the question is whether or not the inflammation that's in the liver will potentially protect them against worse malaria prognosis. So what about Hep C? There have been really hardly any studies on this between Hep C and malaria co-infections. The few studies that have been published suggest that having both will make the disease worse, make both diseases worse. And certainly treatment with Hep C does not worsen malaria. And I guess the question there is whether if you get rid of the Hep C or make the liver more likely to be inflamed by malaria, and it's not. And treatment for malaria does not worsen the Hep C. So at the moment, there's a strong indication for aggressive approach in treating both conditions. So what's the treatment? ACT is the treatment for this, and this is an artemisinin-based combination therapy, usually for at least 2 weeks, and that's an artemisinin-based derivative of a drug plus something else. So our case, he, with the chloroquine, surprisingly recovered fully. And he was discharged from ICU within 48 hours, and he was discharged from hospital and treated with further chloroquine for about 14 days and made a full recovery. Last case is a gift from Professor Obstruction from Norway, so thank you. This is a 40-year-old man, a refugee from Syria. He had a simple liver cyst that was treated surgically in Syria and was now admitted to a local hospital with fatigue, muscle and joint pain, and was afebrile. His CRP was 220. His screen for hepatitis A, B, and C were negative. So he did have a slight transaminitis, but his bilirubin was normal. His CMV was negative. His full blood count was negative. He had no eosinophilia. A CT at the local hospital had shown a calcified cyst in the liver, but also suspected there was some contrast-enhancing possible tumour in the papilla ovata. An endoscopy ultrasound performed, which was thought to be non-discriminatory, and there was some swelling of the ampulla, but no clear tumour identified. I'm just going to play this video and I'll fast forward it, but that's the CT scan showing a markedly dilated biliary cyst that tapers down to nothing. And there's the cyst already visible in the liver as well. So if we just move it along forward, the gentleman went on to have an ERCP, and there the ampullas cannulated. And a cholangiogram is performed. I'll just pause it there. So it shows multiple filling defects in the common bile duct. The cystic duct is not being very well opacified there. And the proximal bile ducts aren't being able to be visualized. And there's these funny shaped sort of filling defects here. So the patient went on to have a sphincterotomy that's being cut now. And the ampulla suddenly gives birth. So these large, weirdly shaped So these large, weirdly shaped kind of masses emerge, and the duct is trawled and more of these things come out. Blah. And the post-procedure cholangiogram, which I'll just flick through, it shows there's much better clearing and opacification of the ducts now. You can see the cystic duct and the proximal bile ducts. So this patient, the fecal assessment had originally shown no cysts or eggs, but the microscopy of the extracted lesions showed echinococcus. He was started on albendazole, and subsequent PCR certainly showed that he had echinococcus granulosus, and the patient is doing well. So just some final comments. The liver is a commonly affected organ by parasites. Pre-existing Hep B and Hep C infection may complicate parasitic infections and treatments. There are cheap and effective ways to diagnose these conditions if we think of them, and management may require a multifaceted approach in conjunction with the ID specialists. And just to finish off, parasitology is fascinating. So I'll just stop there.
Thank you, Purnima. That was really a fascinating talk and beautiful demonstration of the life cycles and the clinical presentations. So thanks very much. We all learned from that. There are some questions in the chat that maybe we could ask you. And I encourage all of you to put your questions or comments in the chat, and we'll try and get to them. So one of the first questions, Purnima, well, I think was about your first case. How long should you treat hydatid cysts with albendazole? Because it seems a little, vague. Usually we treat luminal parasites for what, 1 to 3 days with albendazole. So why this months of treatment? And maybe jot that one first.
Look, I think the fear with the fear with the treatment is several. One is that you probably have variable penetration of the albendazole into the cyst in the first place. And I guess it depends on whether you're using it as a cover. But there can be a prolonged time between when 1 or 2 of these little tiny microscopic seeding that can occur can go anywhere. And if you don't have that prolonged cover, I guess the fear is that you'll then find, where is it gone? So particularly, let's say, looking at where we come into contact with this, where we're treating or helping a surgeon to treat this who's taken it out of the liver. If you don't have that prolonged cover, I think you're just worried about potential seeding and missing it, and then you won't even know where to look for them when they start up again. And we have had cases where they have recurred months after the surgery and thought, oh, well, yeah. So we've had cases like that. So I think how long is unclear, but at the moment, at the very least, we're treating for a couple of months.
Thank you. And then the next question on that case, how commonly do you see reactions after needle aspirations of a hydatid cyst?
The only ones where we've had needle aspirations have been done by extremely brave radiologists. And I can say that the very few that I've been involved with personally, we haven't seen any. So it's not a common thing. And I think that's about picking the case. It's about making sure that you're not exposing the patient to something that doesn't necessarily need exposure, because quite often if you're needle aspirating it, it's a relatively small lesion. So they're often asymptomatic. We've probably found it incidentally. And so then to expose the patient to something that could be quite traumatic for them is, I think, a scary thing. So in terms of the risk benefit at the time you're making that, it's picking those cases that really has probably reflected on our extremely low complication rate.
In those cases you treat medically alone, those small incidental cysts, how do you follow them up? Do you expect the cyst to disappear or not? And how long does it take?
The ones we've treated, the cyst does not disappear. So there's always a question of how long do you keep following them up. The cases where we've actively treated them, we've done with the ID physicians, and whether it's right or wrong, they've used serology to follow it up. I know it's not a great test, exactly, and it's not, and knowing that it's not good and it's not a great negative predictive value. I guess the fact that it's positive in the first place and then becomes negative later on is one of the reasons. I guess you're never 100% sure, but you can follow it up with the CT, and if it's a small cyst and then becomes completely calcified and there's no more activity around it, you could just follow it up. So at the time that we do, when we start the albendazole treatment on these, we've just been following them up with ultrasound scan. And yes, we do follow them up for at least 6 months or so.
Thank you. Thank you. So that leads to Pantong Mark's question. He said, we occasionally have incidental findings of cystic liver disease, asymptomatic, and it's difficult to make a definitive diagnosis. And I really sympathize with that. I mean, just non-infectious liver cysts are fairly common.
Absolutely.
And so how do you decide which ones might be echinococcus and which ones are not infectious?
Yeah, and I think this is probably where we first, so one of the other cases, and I was half thinking of having time to present this, was a case where we were 100% convinced that this was echinococcus. Serology was negative, but the case was just such a great story. She was a woman again, and she was a farmer. We just had nailed that this was definitely going to be hydatid. It was a complex cyst on ultrasound, and she went for surgery. She had a hemihepatectomy, only to find that it was not echinococcus. It was a simple cyst, and sometimes you just never know and you just have to wear it. So she started off obviously on the albendazole. By the time the histology came back with no evidence of echinococcus, well, she'd had a big chunk of her liver removed. Now, you could argue that, if it was big enough for us to be concerned about and wanting to treat, then, okay, in that particular case, maybe the call wasn't such a bad one. But yeah, it can be a very difficult thing. One of the ways we've tried to look at this is to do serology, repeat serology, keep an eye on things, close follow-up. But no, there is not a 100% way of doing it. And sometimes you do wonder whether maybe cyst aspiration, if it's safe, would be a considered way of doing it. Or if you think that it's going to be active, you could just follow it up and see if the cyst changes.
So you mentioned that cyst aspiration was diagnostic. How is that the case? Do you send the aspirated fluid for some sort of test, or?
Yeah, we send the aspirated fluid off for micro.
And what is it? So you're looking for the eggs in the fluid?
Sorry?
So what happens? Are they looking for eggs in the fluid?
No, they can actually do PCR and confirm that there's hydatid in there. Yeah.
Haile Mikhail, do you want to switch to the poll?
Well, the poll questions are up there. Do we want to go and do those? Can't hear you, Haley.
I think he may have to administer it.
I have to?
No, I think Haile Mikhail might have to.
But they were here.
Can you hear me now?
Yes.
Yeah.
Okay. Can you hear the poll questions? So people are responding to the poll questions actually. In the meantime, I just also want to ask one question that I'm facing. So I had one patient, young patient with and he had raised liver enzymes of unidentified cause. But when we really evaluated on ultrasound, we have seen that he had signs of periportal fibrosis. The alkaline phosphatase was very high compared to the other tests.
What was up? Sorry, what was high?
The alkaline phosphatase was it was the mostly raised test with the alkaline phosphatase. So how common do you see raised alkaline phosphatase in patient with schistosomiasis? We have done other tests, other cause of liver disease. It was normal. His biopsy is pending liver biopsy. But on ultrasound, I have seen that he had periportal thickening and he had a risk factor for that.
Yeah, look, I think particularly where you're living, Haley Michael, I think that's a very different scenario to what I would see if in my country. So we would hardly see any schistosomiasis here. So it would be fairly low on the list of causes from our point of view, but from your point of view, it would be very high. And I suspect that just like any other issue in terms of liver function tests, there's no 100% specificity for one thing compared to another. The alkaline phosphatase certainly can go up with increased fibrosis, and we see that with fibrosis from other causes of liver disease as well. So it certainly doesn't rule it out or make it less likely. But again, patients can have more than one condition, and that's where things become more difficult. So I don't know how often you guys see things like PBC or secondary PSC or any of those other conditions amongst your patients, and what the background incidence of those sort of diseases, autoimmune diseases, which would be top of the list of reasons that in our country that we would have that, having not had endemic schistosomiasis. So I think it makes it more difficult when you've got a history like this to say what's underlying it. And the question might very well be for you as to whether it matters to some degree if you have if you have ability to get the serology done, if you have the ability to look for the autoantibodies, I would keep the diagnosis as broad as possible until you can narrow that down, because you can have more than one process going on. And if you think you have enough evidence for acute or ongoing infection with schistosomiasis, you have to treat it anyway. And then the question is, well, if this patient now has burned out schistosomiasis and just has the fibrosis, you're going to have to treat it as a patient who has fibrosis from whatever cause that they had, whether that's an immune-related process or whether it's an infection-related process. There is no other treatment for PSC, and if you can exclude PBC, then I think you just treat them as ongoing fibrosis and see what happens in looking at portal hypertension and the complications.
Thank you so much. I think it's very helpful. And to just show the poll results for the first question, how many active parasite infections do you treat in your practice? So you can see the result. People treat many cases, 1 to 2 per week or per day, and per month has been voted. Do you look for schistosomiasis in your Hep B and Hep C patients when assessing for treatment? Only one says always, and the others respond like only if they present with massive hepatosplenomegaly, and some say never. So I think this will help. The lecture probably will change our mind in that. And the third highlighted disease is managed in your hospital by, so 3 say gastroenterologists, 2 say surgeons, and 6 a multidisciplinary team. Dear Purnima, do you have anything from this share poll results that you want to share us?
Well, I think that involving a multidisciplinary team is extremely helpful. Whether you're partly because the diagnosis, as we've seen, is not always clear, and having more than one aspect of that diagnosis discussed is important. So when it's something like a cystic lesion that you're discussing with the surgeons, what's their risk, what's the risk to the patient, you need the infectious diseases guys on board to say what's the best medication, how long you want to keep it going for, and is there any underlying liver disease, what is going to be the recovery if you take out this much liver, have they got enough liver to live on? So you need a hepatologist, you need an ID physician, you need a surgeon, a liver surgeon to treat all of that. And that's just one example. So I think having a multidisciplinary team approach is extremely important in treating any of these complex conditions, particularly when you have more than one system involved. So I'd encourage for everyone to do that. Anyone who's living in an endemic area should be very au fait, very comfortable with the infections that are in that area, because particularly liver is involved in so many other conditions. So I think that if you're not looking for schistosomiasis, I would strongly encourage you to do so and to be very aware of it.
That's really great. Professor Mark, do you have any?
No, there's lots more I could ask Purnima, but I think we're out of time.
Yeah. Professor Lars, any other thoughts, additional thoughts? The case was fascinating from the ARCP.
Yeah. It was good, wasn't it?
Professor Lars, your mic is muted. Yeah,
I was just wondering why eosinophilia was not mentioned. I thought that might be an indicator of a parasitic infection when you study the cyst, but that's not the case.
Look, I don't think so. We find it as a very non-specific common finding. So eosinophilia is very common in Australia, mainly because we have a lot of grass pollen allergy. So I'd say, about 5% of our children will be eosinophilic at any one time, particularly in the spring. So it becomes quite a non-specific finding in general. Certainly, given its right context, sure, it adds some juice to the mix.
Okay. Otherwise, brilliant.
Yeah. It's really brilliant and exciting. Anyone who wants to have final thoughts? Otherwise, the time is already, it's 5 p.m. Ethiopian time. And it's really nice to have you, Purnima. And this is step 1 of parasite infections in the liver, part 1. So we'll have the next part in another sessions. Yeah.
Thanks very much.
Thanks so much. So after 2 weeks, we'll have another exciting talk by Professor Doa Kulwinder on esophageal stricture, and please join us just 2 weeks after 2 weeks. Thanks so much.
And before you log off, please send your feedback in. You'll have a link in the chat. So please help us with that before you log off. Thank you, everyone.
Bye-bye.
Yeah, bye-bye. And also, you can share feedbacks and what's the other thing? See, yeah, there is also a certificate to those who want to have a CU certificate. You can see, share the feedback via this link. Dagmar has shared the link. So if you want a credit for that, you can send you an e-certificate. You can send your name to Dr. Dagmari, Mikhail, or to me. Okay.
Praneem,